Mr. Flores, you're recognized for 5 minutes.
Thank you, Mr. Chairman. I also thank the witnesses for testifying today. Mr. Makovsky, in your testimony, you referred to something. I think you said high-performance facilities. Is that correct?
High-performing facilities, yes, sir.
High-performing facilities. How many of those are in the VHA system, and roughly where are they?
Well, we found them in different ways, sir. So we found facilities that have a good handle on access, patient satisfaction. I think the acting secretary came back from his visit to San Antonio. And the passion, the mission, the drive, the energy is palpable in some of our facilities. I will tell you that in some cases, entire networks, we did not find facilities that had integrity issues worth us reviewing. And in some networks, we only had selected instances. So both from an integrity perspective and from a veteran-focused perspective, we have high performers who get the process right. Schedule with integrity, report your wait times with accuracy, find resources where you need them, and we have a number of them.
So we have these high-performing facilities that have much better outcomes than the other facilities. What is it that makes it different?
Culture and leadership, sir.
Okay, it's the leadership of the facilities. I'm going to move to Dr. Draper. In your reviews of the VHA, did you find similar high-performing facilities like Mr. Bukowski referenced?
As I mentioned, we see variation in facilities. I think there are some really excellent facilities and some that seem to struggle.
Okay.
And I would agree that, part of it is the leadership issue.
And Mr. Griffin, did you find similarly find high-performance facilities or teams?
If I could expand a little bit, we have done a couple of reviews of the VISN networks, and we concluded that if you've seen one VISN, you've seen one VISN. It seems like if you have high-performing facilities, whether at the network level or the medical center level, you need to export those best practices around the system. There have been issues in the past where a problem has been identified, and you send it out to the medical centers, and in many instances, top leadership in VHA sent out safety alerts and directives and what have you, and they weren't followed.
Okay.
So you've got an accountability issue there, you've got an integrity issue there, but there ought to be a best model for similar sized medical centers so that when a directive goes out, you know, okay, at this facility or at all the facilities, the chief of staff owns this issue, or the chief of surgery, or one individual. But some of our reports, like on reusable medical equipment not being properly sanitized after use, there was no one person at every facility who had ownership of the issue. So, you reap what you sow. And when you send it out there and there's no consistency in ownership, then the results are predictable.
Mm-hmm. And so do you concur with the other two observations that it's the leadership of those facilities that sets them apart from?
I think it's leadership in the field. It's also leadership in headquarters.
Right. Okay. And Mr. Griffin, the interim report cited the need to minimize the chances of evidence destruction, data manipulation, and coaching employees on how to respond to the OIG questions. Do you have any evidence that any of those activities took place, the evidence destruction, data manipulation, or coaching employees?
There's plenty of evidence of data manipulation. Okay. The question of destruction, we had a contact from a Hill staffer the first weekend in May reporting that they had heard there were parties going on destroying documents at medical centers. We responded to 50 medical centers that weekend and didn't find any destruction that we came upon in those unannounced visits.
How about coaching employees on how to respond to the questions of your team?
Our team's questions are not similar to the questions that they were posed by the audit staff that BHA sent out there. All of our interviews were taped interviews. People were put under oath, and we asked them straight up, who told you to do this? Some produced emails. Some said, well, we've always done it this way. the range of answers is what caused us to identify it as systemic, along with all of our previous audits.
And one last quick question. Did you run across any employees that said they would be willing to cooperate, but they weren't because they were concerned about reprisal?
We had anecdotal reports of reprisal occurring around the system.
Okay. Thank you. I yield back.
Thank you, Mr. Brownlee. Mr. Flores for 5 minutes.
Thank you, Mr. Chairman. Mr. Griffin and Dr. Draper, this question is for you. I mean, the testimony tonight and earlier reports that we've gotten says clearly that we have a reporting problem related to the appointments, waiting time calculations, and the way those have been reported. Did your studies of the VHA find any other reporting issues that we have to be worried about? I mean, one of the things, the VA comes and gives us plenty of testimony, and they always are armed with reams of reports. But if we can't trust these reports related to waiting times and patients seeking care, that calls into question other reports. Did either of you find anything in your studies that indicate to us we've got other reporting issues to be concerned about?
Well, we have found data reliability issues with both the wait times and the consults data, the work that we're currently doing. But I think there's another issue. It's not just about the data as well, because we found, and we reported in our 2012 report, that another issue is some of the support systems that go to support the work to schedule appointments and get veterans in for timely care. One of the big things was telephone access for medical appointments. We found that phones, they weren't being answered. You call the VA medical facility. Even, we got complaints from within the facility that people would try to call a clinic and no one would answer the phone or no one returns phone calls. So I think it's a complicated issue. It's not just about the process itself, but some of the supporting systems that help support some of that as well. That's problematic. So it really needs to be a holistic look at how to improve the overall process.
Mr. Griffin.
I think the decentralized nation, or VHA, with 1,700 points of care around the country between the medical centers and the outpatient clinics and various other places where care is provided, makes it very challenging to try and stay on top of what's happening at all those facilities. As I mentioned earlier, when we did an audit of the VISN network, they're all different. Seems like you need to have a better organizational structure that applies to all of the networks. And as was mentioned earlier, the people at the network seem to float back and forth between medical centers and what have you. Now, you either need them or you don't need them. Maybe we need them on the front lines providing health care as opposed to being administrators in networks that were supposed to be Spartan in size when they were first established, and they just kind of grew, and again, they all look different, both from a management structure and from the way they handle contracts.
Okay. Thank you for the testimony. I just have some comments for our VA leadership. I think Americans have received another disappointing reason to not trust big bureaucratic government. I mean, we've had the VHA, the VA disability claims problem that's been out there for quite a while now. Now we've got this new VA issue. Over at HHS, they spend several $100 million and can't build a website for the Affordable Care Act. And so tonight you all have heard comments, when I say y'all, Mr. Matovsky, and I'm assuming some of the VA management's listening to this tonight, but you've heard comments about things like this: question everything, what's the next big idea, form a special operations team, try to institute a culture of putting veterans first. I would say you need to do all those things as you're trying to create the VA of the 21st century. And it should be one that's focused on less bureaucracy and more on taking care of the patient. And that may be a totally different model than what you've got now, which is a heavy, bureaucratically structured system with a lot of bricks and mortars. I would urge you to think outside the box. If we truly put our veterans first, then I think that we're going to find there's a new model needed to do that versus what we're doing today. Mr. Chairman, I yield back. Thank you.
Thank you very much. Ms. Titus, you're recognized.